Hello, Clinic Review family. Today I'm going to continue doing SATA questions. You should expect to get at least 40 SATA questions on your Nclex. And so I know you need practice with these, so let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. I'm very glad to see you again today. I hope you're doing well. Congratulations to all of you who have already passed NCLEX, and those of you who are getting ready to do that. I know you're going to pass this time, so be confident. That's a big deal to be confident. So you know that this channel is a part of the greater Clinic Review organization, and if you go to clinicreviews.com, you can sign up for the 21 plus hour NCLEX review that is taught by the GOAT himself, Mark Klimek. We also have online tutoring. You can buy a month package with 4 sessions of tutoring, or you can get our streaming service. So let's go ahead and get started. You know, many of you know that I teach SATA in a specific way because you need to be as comfortable answering SATA questions as you do answering any other question. So let's go ahead and get started. And what I do is I read the question, I read all the answers, and then I read the question again, and then I turn it into a series of true-false statements. A patient is diagnosed with osteoarthritis of the knees. Which points are important to include in patient education? Apply cold packs before exercise, maintain a healthy weight to reduce joint stress, perform low impact exercises such as swimming, take frequent rest periods to avoid overstressing joints, exercise only when pain-free, use heat therapy for stiff or painful joints. A patient is diagnosed with osteoarthritis of the knees. Which points are important to include in patient education? All right. Well, you need to use common sense and clinical reasoning when you answer these questions. So, osteoarthritis of the knees. Apply cold packs before exercise. Well, cold packs reduces inflammation, but it also vasoconstricts. So that doesn't seem like that would be a good idea. We can ice pack after exercise, but not before exercise. We don't do that. Maintain a healthy weight to reduce joint stress. That seems like a good idea. It just makes sense to do that. Perform low impact exercises such as swimming. That's always good. When we think about joint problems, we want to do low impact. So that makes sense. Take frequent rest periods to avoid overstressing joints. That is a true statement. That seems like a good idea. Because with osteoarthritis, the pain does get worse the longer you exercise. So if you can rest, that is a good idea. Exercise only when pain-free. You know, you may not ever be pain-free. So the key is not so much that you don't exercise when you're having pain. The key is that you don't put stress on the joints. So if you swim or do non-impact bearing exercises, weight bearing exercises on the joints, it should be fine to exercise even if you're having some pain. You can take some pain medication. You can do that. Use heat therapy for stiff or painful joints. That's always a good idea. Heat therapy is good for that. Cold therapy, not such a good idea. Okay. So those are the true statements as it relates to the patient education associated with osteoarthritis. It's not rocket science. Don't turn it into rocket science. Use your common sense and clinical reasoning. A patient is 12 hours post-op from an open bowel resection. Which findings or interventions are indicative of appropriate nursing management to prevent complications? Encourage use of incentive spirometer. Maintain the patient strictly in supine position. Monitor for return of bowel sounds. Remind the patient to splint the incision when coughing. Administer prophylactic anticoagulants if ordered. Ambulation as tolerated. All right, 12 hours post-op from an open bowel resection. All right. So once they're past 12 hours, they're outside of the window where you're worried about them bleeding. So the reason we don't get people up in the first 12 hours is we don't want people to bleed. We need to make sure that they've recovered. So the first 12 hours is when they're considered unstable. So we usually keep them in bed for the first 12 hours. But after they've gotten through that 12-hour period and they're doing okay, we can start to do kind of the typical post-op stuff. So let's see what we've got here. In post-op, open bowel resection, we'd want to use incentive spirometry every 1 to 2 hours. That's true. That is true really for any surgery, but certainly for an abdominal surgery, where they may have reduced coughing and deep breathing. Normally, we want to make sure they're doing incentive spirometry. Maintain the patient strictly in supine position. Supine is laying flat on their back. There's no reason for that. That's not typically, usually we say whatever position is comfortable. So if they're comfortable supine, that's fine. But strictly is a pretty extreme word. There's no reason to be strict about that. Monitor return of bowel sounds after an open bowel resection. That's absolutely what we're going to do. They're not going to be able to eat anything until they have bowel sounds returning. So yes, we have to monitor for that. Remind the patients to splint the incision when coughing. That's a good idea post open bowel resection. Because they do need to cough and deep breathe. That's one of the key things post-operatively that we need to do. And ambulation is another thing that we need to do. Administer prophylactic anticoagulants if ordered. So at first I thought, I don't know about this. You give anticoagulants, but then I'm thinking about it and it says if ordered. Okay, if ordered. So that's a good Nclex answer. And the question is, are anticoagulants contraindicated? And they're not. And in fact, anticoagulants are used to prevent DVT. Surgery is a risk for DVT. And since it says if ordered, it's saying, hey, if they're ordered, can you go ahead and give them? Are they contraindicated? That's really what it means. And I say, well, no, they're not contraindicated specifically for this surgery. So yeah, I would want to do that if they're ordered. Ambulation as tolerated. Yes, we're outside of that 12-hour post-op window, that 12 hours where they're unstable because we're risk for bleeding. So yes, I can definitely start to ambulate them. So that is important to do. So these are kind of routine. It's just really a question of, do you know what routine post-op care is? That's really all it's asking you. You're caring for a newborn whose mother has gestational diabetes. Which signs of neonatal hypoglycemia should you assess for? So how are you going to know if the baby is hypoglycemic? Jitteriness or tremors, high-pitched cry, a blood glucose reading of 58 at 4 hours of life, poor feeding or difficulty latching, diaphoresis, polycythemia. Okay, mom has gestational diabetes. So how are we going to know if baby's hypoglycemic? So I'm not a neonatal nurse. I'm not a pediatric nurse. I hate peds questions. They make me nervous. So what I'm going to have to do is say in general, is this a symptom of hypoglycemia? In general, are jitteriness or tremors a symptom of hypoglycemia? And they definitely are. So I'm going to say yes. In general, is a high-pitched cry a sign of gestation or a sign of hypoglycemia? A high-pitched cry. No, I mean, not with adults, but high-pitched cry seems to be sort of the sign of distress in a baby. So to me, it just sort of makes sense that I would say yes to that, just because it's like standard, the baby's in distress, high-pitched cry. So yeah, that tells me they're in distress. A blood glucose reading of 58 at 4 hours. So this is a number you just have to memorize. In neonates, it has to be under 40 to be considered hypoglycemia. So 58 is okay. Poor feeding or difficulty latching. So I would expect the baby, yes, they could be jittery or tremors, but they could also be lethargic, right? Because if they're hypoglycemic, they could be lethargic. So if they have poor feeding or difficulty latching, that could be because they're tired, lethargic. So that could be an issue. Is diaphoresis a typical symptom of hypoglycemia? It is. It's a sympathetic nervous system response. So yes. Polycythemia. Polycythemia is an elevated hematocrit count. Polycythemia is elevated hematocrit. Now, elevated hematocrit is usually a symptom of hypoxia, not hypoglycemia. So I am not going to pick that. So no. So those are the correct answers. So I just turned that into a series of questions related to what are the signs and symptoms of hypoglycemia. Now, I might have failed to pick one of those if just because I don't really know this, I'm just having to use common sense and clinical reasoning. So if you missed one, it's not the end of the world. You get partial credit. So don't be too hard on yourself. A patient with a pneumothorax, which is a deflated lung, air in the pleural space, has a chest tube in place connected to a water seal drainage system. Which findings or interventions are appropriate? So a water seal means the tube, the chest tube is an occlusive dressing over the chest tube. It goes down into a chest tube device that has a small amount of water in it, and it seals the chest tube. So the water seal prevents air from getting back into the pleural space, but it still allows the air to exit. So that's why we use a water seal. And our biggest concern with a chest tube is that you are going to get air back into the pleural space. That's always our biggest risk. So like if the water seal breaks, we're worried about water getting back into the pleural space. If the chest tube comes out, we're worried about air getting back into the pleural space. So we don't want to have any access for air to get back in the pleural space. So what are the answers here? Change the dressing over the chest tube once a day, continuous bubbling in the water seal chamber, titling in the water seal chamber with respirations, clamping the chest tube routinely for 30 minutes each shift, assess for subcutaneous emphysema around the insertion site, administer an antitussive to prevent coughing. Okay, so let's see. We've got a chest tube. So it'd be appropriate to change the dressing over the chest tube once a day. That's false. We don't actually change the dressing at all. It's an occlusive dressing. It's got a Vaseline gauze. That bottom layer of the dressing is Vaseline gauze to prevent air from getting in, leaking in around. So no, we're not going to change that. Continuous bubbling in the water seal chamber is a good finding. That's actually not true. So we want intermittent bubbling. Continuous bubbling is an indication of a leak. So if you don't know that continuous bubbling in the water seal chamber is bad and intermittent bubbling in the water seal chamber is good, you need to know that for the Nclex. Like very high chance you're going to get that question on the Nclex. Titling in the water seal chamber with respirations. That's actually normal. It's a pressure thing. The titling is just the movement. It's not bubbling. It's just the movement of the water up and down. And that's actually expected. So that's fine. Clamp the chest tube for 30 minutes each shift is appropriate. That's absolutely not appropriate. The rule is you don't clamp the chest tube longer than 15 seconds without a doctor's order. 15 seconds, not 15 minutes, 15 seconds without a doctor's order. So D is bad. Assess for subcutaneous emphysema around the insertion site is appropriate with a chest tube. That's actually true because if you're getting air back into the pleural space, you could also get air under the skin, which is what subcutaneous emphysema is. So you are assessing for that. So that's good. Administer an antitussive to prevent coughing. Actually, coughing is good. Coughing and deep breathing is good when you have a chest tube because it helps reinflate the lung. So you don't want to give an antitussive. You want to do coughing and deep breathing. So A is incorrect. B is incorrect. We want intermittent bubbling. We're okay with titling in the water seal. We don't clamp the chest tube for longer than 15 seconds without a doctor's order. And we want to encourage coughing and deep breathing. And you might say, well, isn't that chest tube going to pop out if you do that? No, the chest tube is actually sewn in. There's a couple little stitches there to keep it in place. So it should not be popping out with coughing. That's not expected. A patient expresses hopelessness and thoughts of self-harm. Which intervention or assessments are essential to ensure safety? So safety as it relates to self-harm. Ask the patient directly if they have a plan to harm themselves. Provide one-to-one observation if the risk is high. Use only cotton gowns and plastic utensils. Avoid focusing on their plan to self-harm. Document the patient's statements verbatim when possible. Encourage the patient to sign a no harm contract and then reduce monitoring. Okay, self-harm, suicide. So to prevent self-harm or to assess the risk for self-harm, ask the patient directly if they have a plan to harm themselves. That is true. This is a key thing to remember as it relates to self-harm, personal violence, or violence against others. We're expected to ask them directly if they are at risk if they're thinking about harming themselves or thinking about harming others. People sometimes are afraid to do that. They're like, but if I say it out loud, they're going to do it. Actually, the research shows that saying it out loud does not make them do it. It actually reduces that risk a little bit by confronting it head on. So we're supposed to directly ask them. So that is a true statement. Provide one-to-one observation if the risk is high. If the risk for self-harm is high, that's a true statement. That's just common sense, y'all. That's just common sense. That's not like you shouldn't have to memorize that. Use only cotton gowns and plastic utensils if they are at risk for self-harm. You do want to use paper plates and plastic utensils, although you still would never give them a knife. So that does concern me a little bit. But we actually don't use cotton gowns because they can use cotton gowns to hang themselves. We have to use paper gowns. You can't hang yourself with the paper gown. So actually C is incorrect. No cotton gowns if they're at risk for self-harm. Avoid focusing on their plan to self-harm. Avoid focusing on their plan to self-harm. Well, that's sort of the opposite of A. Ask the patient directly if they have plan to self-harm. So I can't really do both. I can't really ask them directly and avoid asking them about it. So I'm going to have to say false for D because I know A is true. E, document the patient's statements verbatim when possible. That's always good. That's fine. That's a good answer. Encourage the patient to sign a no harm contract and then reduce monitoring. No, we don't do that. We don't do that. We assess their risk and then we intervene as needed, and we can do one-on-one continuous observation if needed, like get a sitter if they need to. So those are the correct answers. A patient is admitted with pre-renal acute kidney injury. Which findings or interventions would you anticipate? A history of hypotension or shock, distended neck veins and peripheral edema, polyuria, elevated BUN and creatinine levels, immediate dialysis initiation, and IV fluid bolus. So kidney failure or kidney injury is when it could be either pre-renal, which means you're not getting enough blood flow to the kidneys. So pre-renal, not getting enough blood flow to the kidneys. Intrarenal, which means there's been a damage to the kidney itself. Or post-renal, which means there's a blockage somewhere post-renal and it's caused the backup is causing damage. So pre-renal means they're not getting enough blood flow to the kidney. So remember that as we're answering these questions. So for a pre-renal kidney injury, you would expect to find a history of hypotension or shock. And that's true because hypotension, which is also shock, okay, you have hypotension with shock, low blood pressure, you would expect you'd have decreased renal perfusion with that. That's part of the problem with shock. So yeah, definitely. Distended neck veins and peripheral edema would be associated with pre-renal kidney injury. Well, usually pre-renal kidney injury is low volume. It's usually loss of fluid volume or dehydration or shock. And you don't have distended neck veins with any of those problems or peripheral edema. You don't, because distended neck veins are a result of over volume, hypervolemia, over volume. And you might say, well, but they could have peripheral edema if they third spaced all that volume. I mean, I guess they could, but generally peripheral edema is not associated with hypovolemia. And the neck veins is absolutely wrong. So you don't pick an answer because you think half of it might be right. And just get in your head, if you don't know this, peripheral edema is not associated with hypovolemia. Polyuria. Polyuria is increased urine output, so you would not expect that with acute kidney injury. That's the opposite of what you would expect. Elevated BUN and creatinine levels. You would expect elevated BUN and creatinine levels with an intrarenal kidney injury. However, you also would expect it with pre-renal, because if you have decreased blood flow to the kidneys, then you're not going to be excreting the waste like you usually do because you're just not perfusing your kidneys. So it's going to build up in the blood, right? So the BUN and creatinine levels would go up. So that's a true statement. Immediate dialysis initiation with pre-renal acute kidney injury. Usually we just increase their volume. We rehydrate them and see if that works. I would not, in general, I would not say we do an immediate dialysis initiation. That's not typical. And Nclex is testing on general principles, not extreme outlying principles. So I'm not picking E. IV fluid bolus, that's actually the answer I was really looking for, was we have to rehydrate them because they're usually hypovolemic. So those are the correct answers for a pre-renal acute kidney injury. A patient has been taking lithium for bipolar disorder. Which patient's statements or findings indicate proper understanding and management of lithium therapy? Okay, lithium therapy, lithium, sodium, potassium. Lithium is a electrolyte, and it's considered a metal. If you look at it on the periodic table, it's listed as a metal. So one of the side effects of lithium is a metallic taste in their mouth. So sometimes they can have a metallic taste in their mouth. And because it's an electrolyte, they can have some peripheral neuropathy as a side effect. Okay, so that could be a side effect as well. So that's just something to think about. I should maintain a consistent intake of sodium in my diet. I can stop taking lithium once my mood improves. I will have my lithium levels checked regularly. I should limit my fluid intake to avoid diluting the medication. I will let my provider know if I experience tremors or confusion. I will take an extra dose if I feel my mood slipping. All right. So lithium is like any electrolyte. It has to be controlled in the body. You can overdose on that electrolyte. I should maintain a consistent intake of sodium in my diet. So sodium, if you remember, lithium is an electrolyte. Sodium is the other electrolyte that can affect lithium levels. So as sodium level goes up, lithium level goes down. And as sodium level goes down, lithium level goes up. So they do have to have a consistent intake of sodium while they're on lithium. So that is something to remember. I can stop taking lithium once my mood improves. Hopefully you would not pick that one. Bipolar is a chronic disease, and their mood improves because they're taking the lithium. So don't stop taking it. I will have my lithium levels checked regularly. That's true. Like if you're taking any electrolyte, you have to have them checked regularly. I should limit my fluid intake to avoid diluting the medication. Actually, that's not true. Maintain adequate fluid intake. So we don't want to dilute it, because otherwise, if you become dehydrated when you're taking any electrolyte, the electrolyte level goes up because it's just concentrated in your body. So no, keep the normal amount of fluid intake. I'll let my provider know if I experience tremors or confusion. Well, it is an electrolyte, so you can have neurologic changes is a symptom of toxicity, and tremors and confusion is not neuropathy. Neuropathy is a side effect, but any additional neurologic symptoms would be considered toxic effects. So I would have to let the provider know if they experience tremors or confusion. I will take an extra dose if I feel my mood slipping. No, that's not how we take prescription medications. So remember, if you don't know the answer, go general, not specific. Say, in general, do I tell patients to take an extra dose of prescription medications? Absolutely not. We don't tell people to do that. In the emergency department, after a multi-casualty incident, you have several patients awaiting triage. Which patients should you prioritize for immediate life-saving intervention? So we're looking for the unstable patients. Patient with a 3-inch laceration on the arm and controlled bleeding. Patient who's diaphoretic, confused, and has a weak carotid pulse. Patient with open fracture and stable vital signs. A patient who's unresponsive, not breathing, and has no pulse. A patient complaining of moderate chest pain and shortness of breath. A patient with respiratory distress and minimal air movement. Okay, so we're looking for the unstable patients who can be saved. This is a multi-casualty incident, and so not only are you looking for unstable patients, but you want to look for the ones that can be saved. In a multi-casualty incident, you're going to spend time on the people who are have a high probability of surviving. A patient with a 3-inch laceration on the arm and controlled bleeding, that patient is stable. So they're not my priority. It's not that we're not going to treat them. They're not my priority because they're stable. Patient who's diaphoretic, confused, and has weak carotid pulses. Now that person sounds unstable to me. I don't know why they're confused and have weak carotid pulses, but they sound unstable to me. So I'm going to prioritize them. A patient with an open fracture and stable vital signs. So if you have a diagnosis and a modifying phrase, the modifying phrase is stable vital signs, and you have a diagnosis, which is an open fracture, you actually are more concerned about the modifying phrase. So even though they have an open fracture, their vital signs are stable, which means they're stable. If they tell you they have stable vital signs, then believe them. The patient is stable if they have stable vital signs. So we're not going to prioritize them. A patient who is unresponsive, not breathing, and has no pulse. This person is dead. Okay, they're dead. So we're not going to prioritize them. A patient complaining of moderate chest pain and shortness of breath. I mean, they could be having a heart attack. They sound unstable to me. So I'm going to prioritize them. A patient with respiratory distress. That's a prioritization. And minimal air movement. That's definitely. So the modifying phrase is minimal air movement. So the respiratory distress says I'm concerned about them. The minimal air movement tells me I'm still concerned about them. So I'm going to pick that one. Okay. All right. And what I'm doing is I'm teaching you how to answer test questions. So you might go, but the person with the open fracture, I mean, they could be hemorrhaging out. Actually, they couldn't be, because if they were hemorrhaging out, they would not have stable vital signs. So you only know what they tell you. So you cannot say they could be doing this. If you're saying they could be, maybe, but if you say all those words while you're answering questions, you're about ready to get the question wrong. You have to pay attention to the words they give you, believe the words they're telling you, and make decisions based on that, not on possible, maybe, if, could, any of those words, might. None of those words are good to use in your thinking when you're taking the Nclex. A patient with leukemia is severely neutropenic. That means low white count. Which interventions and precautions are most important at this time? So we're thinking they're at risk for infection, right? Place the patient in a private room, encourage fresh fruits and vegetables for immune support, use strict hand hygiene before entering the room, restrict visitors with signs of infection, administer prophylactic antibiotics as ordered, allow fresh flowers in the room to improve patient morale. All right, so neutropenic precautions. I don't know about you, but the one thing I know for sure that we don't do is we don't bring a bunch of fresh fruits, flowers, and vegetables because it could be carrying germs, it could be carrying bugs. I don't know what it's carrying. So we don't do that when there are neutropenic precautions. So I know B and F are out, and I know we have to wash our hands. Okay, so I know C is in, I know B and F are out. Okay. Place the patient in a private room. Well, that seems like a good idea. I don't really want them in the same room with someone who has, an infection or some other issue, right? Because they're extremely immunocompromised. So they really need to be in a private room. I already said use strict hand hygiene, restrict visitors with signs of infection. Well, they're immunocompromised. So of course I'm going to restrict visitors with signs of infection. So the question is, the only one that I'm not positive about is administer prophylactic antibiotics as ordered. So I may say, I don't know, prophylactic antibiotics. Do we give prophylactic antibiotics? We have all this antibiotic resistance. Are we supposed to do that? So I really can't get caught up in that. I have to say this person is extremely immunocompromised, so they are at risk for infection. So prophylactic antibiotics might be used, and it has two words in it that I like for Nclex. It says as ordered. So I go, well, if they order them, I mean, it's not contraindicated. And they are extremely immunocompromised, so I don't see why not. So I'm going to go ahead and pick all of those answers, okay? So I hope you're listening to how I'm thinking and learning how to think, because that's the whole point of doing these videos with me. Okay, it's the whole point. Yes, you need to do about 2,000 questions before you do the Nclex, but if you're going to do 2,000 questions, you have to think the right way. You don't want to just be doing, oh, I did 2,000 questions. No, you got to be thinking, actively thinking, using clinical reasoning, common sense. And so by watching these videos with me, you should be learning how to think the right way. Okay. All right. Good luck on your Nclex. Thanks for being a part of the Clinic Review family.